Oh, that's going to be a very, very bad year.
Good morning, everyone.
Yes, you're not.
I do apologize for the late beginning. We were all so prompt, and I'm looking at that clock, which now that I stare at it for a while, is the second hand is moving very, very slowly. So that maybe has a low battery. So my apologies for the late start. We will try to make up time as we move through the day. So my name is Deidre Gifford, and I am the Executive Director of the Office of Health Strategy here in Connecticut. This is a very big day for us at the Office of Health Strategy and for the state of Connecticut. So we are delighted that all of you are here to join us. We're delighted to have whoever is watching with our colleagues at CTN or on the OHS YouTube channel. I'd like to begin with a few notes of thanks before we dive into a very full day of really, really interesting conversations that we are anticipating. First of all, I'd like to acknowledge the team, the very hardworking team from the Office of Health Strategy. We have Olga Arma, please raise your hand so people can acknowledge you. Krista Moore, Janita Thompson, Cindy Dubuque Gallo, Art Combs' friend from Cronin, Anne-Marie Kemp, and a very, very special shout out to Abby Alter, who was the key planner for today, who dove into this work just very recently and really did an excellent job of planning. So thank you, Abby, very much. I'd like to thank our colleagues at Baylor Health, who you'll hear from shortly and who have been by our side since the beginning of the cost growth benchmark work in Connecticut. All of the panel co-hosts and speakers whom I will be introducing one by one, some of whom have traveled a great distance to be with us today and who are national experts in their field. We're extremely lucky to be joined by them today. I really want to thank our legislative colleagues for being here. Some of whom have said they're actually planning to stay the entire day. So that is a bonus. We understand you all have a lot of things on the agenda and you may need to be in and out, but we're delighted to have you here to hear the conversations and to help us think about the challenges of healthcare cost, quality, and access. I'd like to acknowledge my predecessor at the Office of Health Strategy, Vicki Beltry. Many of you know Vicki, and we are here today in large part because of the hard work that she did in the many years that she worked at the Office of Health Strategy. So Vicki, if you're watching, thank you for helping us get to this day. I also want to acknowledge Kelly Cinco, who was the OHS Director of Policy and who has taken a new position at the Department of Mental Health and Addiction Services. So we miss her, but she is still part of the state team. So today's hearing is step 2 of a 3-part cycle for the Cost Growth Benchmark Initiative in Connecticut. The first step of this annual cycle was the March report that we released that gave our benchmark results for 2020 and 2021. The target benchmark was growth was 3.4%. Our overall growth was 6%, so we did not meet our target in that first year. The second part of the annual cycle is today's hearing, and the third part is a report and recommendations that OHS will produce and deliver to our committees of cognizance later on in the fall. So we have a three-part cycle, and there are three main topics for our benchmark. There's the cost growth benchmark, which we'll be discussing today, but we also have quality benchmarks and a primary care spending target that are part of the overall process. And we will be releasing those benchmarks and reports at future dates. If you will indulge me, I wanted to just read a few lines from the statute about today's hearing, because I think it's important. It sort of sets the context and it helps everyone understand when our partners in the legislature passed and the governor signed this legislation, what was intended for today. This is under Connecticut General Statute 19A 754J. Not later than June 30th, 2023, so we're sliding in under the deadline, and annually thereafter, the executive director shall hold an informational public hearing to compare the growth in total healthcare expenditures in the performance year, that's 2021, to the healthcare cost growth benchmark established pursuant to 19A 754D. Such hearing shall involve an examination of the report most recently prepared, an examination of the expenditures of provider entities and payers, including but not limited to healthcare cost trends, primary care spending as a percentage of total medical expense, and the factors contributing to such costs and expenditures, and any other matters that the executive director, in the executive director's discretion, deems relevant for the purposes of this section. The executive director may require any payer or provider entity that for the performance year is found to be a significant contributor to healthcare cost growth in the state or has failed to meet the primary care spending target to participate in such hearing. Each payer or provider entity that is required to participate in such hearing shall provide testimony on issues identified by the PED and provide additional information on actions taken to reduce such payers or entities' contribution to future statewide healthcare costs and expenditures, or to increase such payers or provider entities' primary care spending as a percentage of total medical expenditures. So thank you for indulging me. The reason why I wanted to read that statute is just to acknowledge that this is our first time through this exercise in Connecticut. And there's been a very understandable back and forth with the individuals who have and entities that have been invited to participate today. And I really want to say thank you to all of those that are here. We know that it wasn't necessarily a pleasant experience to receive the letter inviting you to come before us at this hearing. And that there were a lot of questions in trying to understand how OHS arrived at the people that we would invite to testify. So we're grateful for the back and forth we've learned through this process, all of us have. Next year, we'll build on those learnings. When you hear from Michael a little bit later, he'll talk some more about the process that OHS has used to identify the invitees. We want to be transparent and inclusive. And also, it's important to say that not every significant contributor to healthcare cost growth could, of course, be invited. So we try to be fair and representative in those that were invited. We did invite AbbVie to be here today. And under that statute, AbbVie will not be appearing. That's unfortunate. We are grateful to Bristol Myers Squibb, who is here to talk about pharmacy prices. The last thing I'll say is that some of you were present for the governor's bill signing yesterday. Many of you may have seen clips of it. And the tone, I think, that was set in that event is very important for this exercise today. The tone is that this is about affordability of healthcare for the residents of Connecticut. That's why we're here. We want this to be a respectful interchange. No doubt there will be difficult questions and topics that will be brought up because this is a difficult and challenging set of issues. But we want and know, are confident that this will be a respectful event that will lead to importantly recommendations that we can bring to the legislature and the governor for next year. So with that, let me just review our agenda for today. It's a terrific agenda. We will start off the day with some opening remarks from members of our Connecticut General Assembly. We will then hear directly from a consumer and an employer purchaser here in Connecticut about their views on the benchmark. Then our consultant, Mike Taylor, will lead a review of the healthcare cost drivers in Connecticut and how we identify the entities that were invited to participate. The next part of the agenda will focus on 3 separate panels where we will be asking pharmaceutical companies, health insurers, and hospitals questions about their institutions deriving healthcare costs in Connecticut. And finally, at the end of the day, we will wrap up with a roundtable discussion with key Connecticut healthcare providers. So that is the run show for today. We're very much looking forward to it. With that, I'd like to offer our legislative colleagues, beginning with Representative Nicole Claridis-Dutria.
Thank you very much, Commissioner. Thank you for having us here today. I'm looking forward to a robust conversation as to what we can do in the state of Connecticut. We constantly talked about yesterday, affordability and accessibility. During the session this year, we passed 2 really important bills for the state of Connecticut, SB 9 and HB 6669. I think those bills, in conjunction with the other things we're doing in the state of Connecticut, is our goal to make healthcare affordable and accessible in Connecticut. So being here today, having those tough conversations, hopefully will move us forward and continue to do the good work that you spearheaded here in Connecticut and the governor. Thank you.
Thank you, Representative McCarthy.
Thank you very much, Dr. Gifford, and it's a pleasure to be here with all of you. I'm Kristen McCarthy-Bakey. I co-chair the legislature's Public Health Committee, and I'm in my first year. And so I'm here to listen and learn about one of the most important issues facing the people of our state. I talk often about how we seek to help our constituents and our fellow residents be healthy, safe, and strong. And in order to be healthy, they have to be able to afford and have the ability to do that. So I look forward to the conversation today and the ongoing work that we have to do.
Thank you, Senator Summers.
Yes, good morning, everyone, and thank you all for being here. My name is Senator Heather Summers. I've been on the Public Health Committee probably the longest of people that are here. Maybe not, but I want to thank our chairs and my fellow ranking for all their work they've done this year in public health. We're just coming off of the bill signing for 6669 that we all worked on in a bipartisan manner to help increase wellness and help reduce healthcare costs here in the state of Connecticut. And I think that's a great first start. One of the things that I've been thinking about today is that we have been trying to cut healthcare costs in the state of Connecticut for decades, and we're still not able to do that or to control the costs. Sometimes the cost increases are beyond our control, and I think that's what we're here to find out. But I do think that today and the lens in which we're trying to look at healthcare costs really gives us an opportunity to nail down what are the drivers and how do we react to those drivers. It's an opportunity to ask a lot of questions. They may be difficult and uncomfortable. They're not meant to be difficult and uncomfortable, but we have to ask those tough questions, all of us here, to be able to get to the root cause of the rising costs of healthcare. It's unaffordable for many of our residents in the state of Connecticut, especially our seniors. Families spend an extraordinary amount of their disposable income on healthcare, whether it's insurance premiums, and then on top of that, they have to pay out of pocket. And it's becoming to a crescendo point where it's just not affordable for them, which is a bad state for us here as the state and as a nation. The cost for healthcare, it's a complex system. There's manufacturers, there's distributors, there's PBMs, there's malpractice insurance for clinicians, there's reimbursement for Medicaid and Medicare, and there's no easy single way to just say we're going to do this and it's going to fix everything. So that's why we're having these long and in-depth conversations. But I do think that it's important for us to be able to ask questions of the people that are going to be testifying today, and again, sometimes it's not to make you uncomfortable, but I think we need to look at, you know, the profit areas, profit drivers, how that money is spent. I know in the 340B particular program, I want to make sure that pharmacy benefit managers are actually using the excess money, and hospitals are using that to lower healthcare costs. We have no way to prove that at this point in time. And also looking at fees, et cetera. But I wanted to thank everybody for being here. I think this is a good opportunity for us to try to get to the root cause of what are the drivers and how we can react in a positive way, while understanding that businesses that are in this business, whether it's pharmaceutical or pharmacy, et cetera, nobody expects you to not make a profit. You know, that's not where we're going. But it is just important to understand where that money is being spent, and primarily how it affects the patient and how is the quality of care for that particular patient spending an exorbitant amount of money on healthcare. So thank you for all.
Thank you, Senator. I also want to acknowledge our other legislative colleagues, Representative Wood, who is co-chair of the Insurance and Real Estate Committee, Representative Del Nicky, and Representative Deming. Thank you very much for being here. We appreciate it and look forward to beginning the work of getting proposals ready for next session. With that, I would like to move on to our first speaker. We're very lucky today to be joined by two people who really have firsthand knowledge of the barriers facing consumers in affording healthcare here in Connecticut. Our first speaker is Chris Ulbrich. He is the Chief Executive Officer of Ulbrich Stainless Steel and Special Metals. Thank you, Chris, for your participation in the cost of hearing committee and for being at today's hearing. We welcome your remarks and observations.
Well, good morning. Good to be here. And thanks for everybody working on this such important big subject. You know, was it 18% of our GNP in the nation? So it's so important. So I'm Chris Ulbrich, CEO of Ulbrich Stainless Steels and Special Metals in North Haven and Wallingford. We are a processor of 170 different metal alloys worldwide. We have 750 team members, which 300 are located in Connecticut, and we provide medical coverage to 650 people in this wonderful state. You know, it's interesting that our medical coverage was free to our employee base until 1988. We decided to go up 50 cents a week. Those were the good old days, right? Yeah, 50 cents a week. We were panicking that we're going to have a revolution in the company, but obviously we're cost of one. You know, today our employee plus family weekly contribution is $151 a week times 52, right? So, but my biggest concern is the future. You know, by 2025 here, we could see 20% plus increase to make up for the COVID time issues. And I have some reports here. By 2030, we have a 60% increase from the results of today's baseline. And that would put our families close to $250 a week if some of these increases happen. $13,000 a year plus co-pays, etc. in 7 short years. And it's very possible that this could happen. And this is not good, taking this kind of money out of the state of Connecticut just for medical, and when people could be spending it on a lot of other things. So, and I have not focused on the business community cost here, but just on the families. So we're in a real world unsustainable system. Costs are out of control in the medical system. You know, there's poor access, unequal care in different communities, and specialty drugs are now adding to the burden. You know, we were doing really well with specialty drugs. You know, only 15% of our plan was that. Now it's shot up to 50%, like everybody else. So we need everybody in state government to focus on this in future sessions and to help the Connecticut families. And there's things that can be done by working together. So thank you very much for listening.
Thank you very much, Chris. As I mentioned to you earlier, the involvement of employers is so critical to this effort. And we're really interested in getting more small, medium, and large employers in the state of Connecticut involved in issues of cost and affordability. There's a lot that employers can do in working with their third-party administrators to drive down the cost of healthcare, and we really want to make sure that those conversations are happening. So we very much appreciate your leadership in that area and your sharing your really striking comments about what it means for your employees and for your business. Next, I'd like to introduce Margaret Lewis, who is from Stratford, Connecticut. Margaret is a healthcare consumer. We're very grateful for her offering to be with us today to share the impact of healthcare affordability in her life. Thank you.
Thank you so much for inviting me. As you said, my name is Margaret Lewis. I'm from Stratford, Connecticut, which is part of very expensive Fairfield County. But a bit of background as to why I'm here. I'm a former highly compensated marketing executive. I suffered a debilitating stroke when I turned 55. I am on disability, which means a fixed income due to my continuing health issues. I have multiple high-cost prescriptions just to stay alive. I'm fortunate, however, my husband works at Sikorsky, and he has very good insurance and with good coverage most of the year, so I think it's a good place for it to be. But when the calendar year ends, I am shocked by how much I have to pay for certain drugs before our deductible kicks in. My most notable experience has been with the prescription drug Entocort, which is also known as a form of budesonide, and it's prescribed for intestinal issues. I depend on this drug to relieve both pain as well as to assist the daily digestion of my food. I've been on the drug for several months. When my usual 90-day prescription came up for renewal, it was in January of the calendar year, so that meant I had not met my deductible yet. I had gone to get it refilled at the pharmacy, and very calmly, the clerk handed me a little package of my drugs and said, "That'll be $3,000. I was floored. It's like a mortgage payment basically to some households to be asked to pay $3,000 to stay alive. Embarrassed because I didn't have that money with me right then and there. I kind of skittered away, slithered away from the counter, and I did not take the thing. Certainly, I could have taken a 30-day supply and cut that perhaps down to $1,000, but I knew I would be in the same place in 2 months. That for the next 2-month period. When I got home, I searched the internet, and I was desperate to find a way, a less expensive way to get the drugs I needed to stay alive. As I searched, I found that CVS, Rite Aid, Walgreens, some of the big places that we all go to every day for our prescription, were all pretty much the same price for this drug. And what surprised me even further, I looked into like GoodRx, a discount type of place to, just get what I needed quickly. And they were all the same price. It was not something that I could kind of argue. I finally went to my local Stop and Shop pharmacy and practically begged the technician to help me find a way to get this medicine. I mean, if I go for a full day without it, I get effects right away. She used something called a discount card for her work, which was different from what I had access to. And she said it was reserved for people with no or bad insurance, which I would not describe me as one of those people, but I could certainly be sympathetic to those who are in that situation. The 30-day supply ended up being around $60. As of last week, I still saw prices for this drug at $949.24 for a 30-day supply. That's a huge difference. So two questions arise in my mind as a consumer. Why is the cost so high for drugs that are necessary for the very life and existence of our Connecticut consumers, especially seniors? Where are people on restricted incomes supposed to come up with $8,000 for the prescription they need? And secondly, well, I also think that having to choose between paying for the prescription or food or rent is an unfair choice to ask people in the United States. Secondly, though, while I do understand the need to make profits, and I do, I'm a businesswoman, we all know that it probably does not cost $949 to produce 30 pills, especially when you go down to a $60 amount that they ask you. If I didn't know to ask, I would be without money. That's right. So why is that? There is something wrong with our system that, that is causing such disparity. And I am not here to complain about prices because I said earlier, I understand profit, I understand research, I understand overhead, I understand packaging, but there has to be a way for us to work together to find a solution to this problem. It's gotten out of hand. Thank you so much.
Thank you so much for sharing that personal story that I think really focuses us on the purpose of why we are here today. And as I mentioned to you when we met this morning, that the goal of this is to keep the residents of Connecticut at the center and the affordability of healthcare at the center of the conversation. There was a survey in Connecticut in 2022 that showed that 55% of the respondents had experienced at least one healthcare affordability burden in the past year. So you're not alone. The majority of individuals in Connecticut are experiencing that, and nearly 4 in 5 of our residents that responded to the survey are worried about affording healthcare in the future. And very concerning to all of us is that lower income individuals, people of color, and people with disabilities are the most adversely impacted by these healthcare challenges. So it impacts access, it impacts equity, and it impacts healthcare outcomes. So thank you very much for helping to focus our conversation this morning. It's really important. Now I'd like to turn to our able consultant from Baylor Health, Michael Baylor, and also Grace Flaherty from Baylor Health. We're going to give an overview of our benchmark process and our process for selecting individuals to participate today.
Good morning. I think Chris and Margaret have put in personal narrative why we're here today. I want to share just a few selected data points that contextualize why we're here today, and then my colleague Grace will review the 2021 performance results for the cost growth benchmark for today. So the first point I want to make is that healthcare is really expensive in Connecticut. The average Connecticut family premium is $24,000 a year. That is more than what it costs to buy a new compact car. It's 1.5 times what it costs for full-time child care for an infant in Connecticut. Just to put it in context, how much a family premium costs. That's the premium. That's not the cost associated with deductibles and co-insurance. It's just the premium. The healthcare in Connecticut is not only really expensive, but it's also growing at a fast rate. And 2021 was particularly a bad year. Healthcare spending in the commercial market in Connecticut grew 18.8%, while median household income dropped. Now, 18.8% was in the context of a drop in spending in 2020 because of the onset of the COVID-19 epidemic. But I want to note that 18.8% is particularly high because when we compare Connecticut to all of the other states that have cost growth benchmarks, Connecticut had the highest rate of growth in commercial spending. And as you can see in this graph, that Connecticut's rate of growth was 100% higher than Rhode Island's, our neighboring state, and 50% higher than Oregon. So these are big differentials that indicate that not only is healthcare very expensive in the state, but the rate of growth is not at a sustainable level relative to what it can be based on what we see in other states. So high and fast growing healthcare costs are a financial problem, but they're not only a financial problem. As you just heard in heartrending narrative, they're also an access problem. So when healthcare is really expensive, then patients can't access services. And this happens for a couple of reasons. One is employers faced with ever-growing premiums do something, they do one of two things. They stop offering coverage, or they do something called buy down coverage, which means they increase the size of deductibles in coinsurance, which shifts the cost to patients. And what do patients do? They delay accessing care, or they avoid seeking care altogether. As DJ referenced, there was a 2022 survey of Connecticut residents, and that survey revealed that nearly half of the respondents said that they delayed going for care or went without care altogether in the previous 12 months. So I just want to emphasize, high healthcare costs are an access problem. They're not just a financial problem. People are not accessing and receiving services because of the associated expense. So why are Connecticut healthcare costs so very high? There are multiple factors, but one thing is clear, and that is that in the state of Connecticut, high prices play a major role. Not the only role, but a major role. So the next information I'm going to share is from a national organization called the Healthcare Cost Institute. And it looks at prices in Connecticut relative to prices in the neighboring states of Massachusetts and Rhode Island. So this is all prices you see here. And prices in this analysis looked at 189 metropolitan areas in the United States for 2020. And in Hartford, New Haven, and Bridgeport, the prices were 21, 29, and 33% above the national average for these 189 metropolitan areas. That compares to, for Springfield, Worcester, and Massachusetts, -1, +13, +16, and Providence, +12. So much higher prices in Connecticut than in Massachusetts and in Rhode Island. This is especially true when it comes to hospital prices. So this is the same analysis, but it's looking just at inpatient hospital prices. And here you can see the differences 27, 38, and 45 for Hartford, New Haven, and Bridgeport. That compares to -1, +5, and +7 for Springfield, Worcester, and Boston, and +12 for Providence. Okay, so even larger differentials. That's for inpatient. For outpatient services, Connecticut is not as far above, but if you look at Massachusetts and Rhode Island, they're actually significantly below the national average. So prices are certainly an issue explaining why healthcare costs are so high in Connecticut. Again, they're not the only issue, but they are significant. So in summary, healthcare costs in Connecticut are very high. They grew quite rapidly in 2021. They are a financial burden to Connecticut residents that impede access to services and that will contribute to compromising the health of the population. So there is opportunity for all of us, great opportunity. And I'm now going to ask my colleague Grace to share with you specifically the results of the 2021 cost growth benchmark in the state. Oh, I'm sorry. I had one last slide, I forgot. So for all of this spending, healthcare quality in Connecticut is not better than in Massachusetts and Rhode Island. So these data come from the Commonwealth Fund and from their 2022 state scorecard. I'll note that they updated the scorecard just last week, and I didn't incorporate the new findings, but they're not dramatically different. So for example, on quality here, you can see that for prevention and treatment, Connecticut ranks number 5, Massachusetts number 1, and Rhode Island number 6. So quality very high in all 3 states. And so we can't say that the higher spending and the higher prices in Connecticut are justified by higher quality, because we don't see that here in the Commonwealth Fund assessment. I'll also note that employer-sponsored insurance spending per enrollee is much higher in Connecticut than in Massachusetts and Rhode Island. And that's despite Connecticut, relatively speaking, making a pretty good investment in Medicaid. So Medicaid spending in Connecticut is ranked 7th in the country, Massachusetts 1st, and Rhode Island way down at 28th. So the high prices aren't resulting in higher quality, and it doesn't appear that significant underinvestment in Medicaid, at least relative to other states, is a major contributor to the higher than compared prices in Connecticut. Okay, so with that, I'm going to transition now to Grace, and she's going to explain to you how measurement of 2021 cost growth benchmark performance was performed and what were the results.
Thank you, Michael. As Michael said, I will be providing a high-level overview of the results of OHS's 2021 healthcare cost growth benchmark analysis. This will be a summary of the high-level results, and I will be guiding us towards the key cost drivers as found in this analysis. But should you want to view or read the detailed results, they are all included in the report that OHS published back in March. First, I'd just like to start with a summary of the cost growth benchmark programs and some brief methodological notes. The cost growth benchmark is Connecticut's target for annual year-over-year growth in per person healthcare spending or total healthcare expenditures. The target value in 2021 was 3.4%. This target decreases down to 2.9% by 2023 through 2025. These benchmark values were set with the help of OHS's tactical team and are based on a blend of forecasted potential gross state product and forecasted growth in median income, with the rationale that healthcare spending should not be growing faster than folks' incomes. When we talk about total healthcare expenditures at the state level, we're talking about 2 things. First, total medical expense, or TME, which means all incurred expenses for Connecticut residents for all healthcare services, regardless of where it was delivered or the size of the member's plan. Also included in total healthcare expenditures is the net cost of private health insurance. This is what we know as administrative cost or profit or loss. Together, these 2 components are what we're assessing against the benchmark at the state level. OHS also assesses performance at 3 other levels. So in addition to total healthcare expenditures at the state level, OHS looks at the growth in total medical expense at the market, insurer, and advanced network level. The market levels are the commercial, fully and self-insured lines of business. Medicare at the market level includes Medicare Advantage and Medicare fee-for-service. And Medicaid includes spending for both dually and non-dually eligible members. At the insurer level, we include performance for the commercial market, again, for the fully and self-insured lines of business, and for Medicare for fee-for-service and managed care. And then for the advanced networks, OHS publicly reports performance on entities that meet a minimum threshold of about 5,000 lives per market. I'll note that I won't be including reference to specific advanced network or large provider entity performance today, but detailed results at the provider level are included in the report that was published in March. I'll note that the administrative costs or profit and loss are not included when we're looking at performance at the market, insurer, and advanced network levels, or market or insurer levels rather, and I'll explain why in a few slides. Our data sources for the results I will show in a moment come from several sources. They primarily come from aggregate spending submitted by carriers. That would be for the commercial and Medicare managed care markets. OHS also requests data from the Department of Social Services for Medicaid, as well as from CMS for Medicare fee-for-service spending. Finally, OHS also requests spending on the veterans population, as well as from the Department of Corrections. An important note about the results I'll be sharing today, we'll be looking at data from 2019 to 2021. Obviously, we cannot talk about this time period without taking into account the COVID-19 pandemic. As Michael referenced, in 2020, there was a dramatic decrease in utilization and spending, which we then saw rebound in 2021. However, as we'll see for certain markets in Connecticut, that was much greater for both certain markets and compared to our neighboring states. When we report performance at the payer and provider levels for 2021, OHS acknowledges that 2021 performance was impacted by this unprecedented circumstance, and more entities exceeded the 2021 benchmark than, and by a larger amount than we would expect under normal conditions. Now, for a high-level review of the 2021 healthcare cost growth benchmark results, as Dr. Gifford mentioned, statewide, Connecticut exceeded the 3.4% benchmark with 6% growth from 2020 to 2021. The commercial market also exceeded the benchmark at an 18.8% year-over-year per capita trend. Medicare and Medicaid saw a much more modest trend at 1.4% and 0.8% respectively. All 5 commercial payers exceeded the benchmark for 2021 cost growth, and 3 of the 4 Medicare Advantage payers exceeded the benchmark for 2021 cost growth. And finally, all advanced networks exceeded the 3.4% benchmark for commercial cost growth, and all except 2 for Medicare Advantage cost growth. Zooming in on the state level results, this graph you're seeing here depicts the trends Connecticut experienced in total healthcare expenditures for 2020 and 2021. The per capita healthcare costs decreased from 2019 to 2020 by 3.1%. I want to note that this decrease in per capita spending does not include the significant federal payments that were made during the COVID-19 pandemic. Had we included those in 2020 spend, we would have seen, in fact, or we anticipate that we would have seen an increase in spending. This decline in spending at the state level, this 3.1% decline is comparable to our neighboring states. Massachusetts and Rhode Island, who also have benchmark programs, saw their 2019 to 2020 statewide trends decrease. Massachusetts trend was negative 2.3%, and Rhode Island's was negative 2.9%, so comparable to Connecticut. However, this is a bit of a different story in 2021. In Connecticut, healthcare cost growth rebounded at the state level from the pandemic to 6%, again above the 3.4% benchmark. This is compared to Rhode Island, which experienced a 3.2% increase, and compared to Massachusetts, who was slightly higher at 9%. Now, given the COVID-19 pandemic, we did calculate an average increase over the 2 years from 2019 to 2021, taking into account that COVID was an aberrant year. We knew spending growth was going to be higher than expected cost growth. So if we look at the 2019 to 2021 average, this comes out to 2.7%. When we look at aggregate spending in Connecticut in 2021 was $34 billion. You can see the breakdown by market here. The commercial market comprised the largest portion of spending, and it is also the portion of spending that is growing the fastest. The small slivers on the top of the bars represent insured administrative cost and margin and other public sources, which includes Department of Corrections and Veterans Administration spending, which comprise a very, very small portion. This slide focuses in on the net cost of private health insurance, the profit and loss. Now, as we can see from this figure, NCPHI tends to be volatile, and we know this because insurer profits tend to vary from year to year, but this time period was particularly volatile because of the COVID-19 pandemic. In 2020, insurer profits grew because there was the unexpected drop in utilization. And then conversely, in 2021, margins shrank because utilization went back up. When I'm going to talk about TME trends or total medical expense trends by market in a moment, I will be only focusing on medical spending and pulling out this NCPHI spending that you're seeing here because of this volatility. Now I'm going to discuss medical expense trends by market, first starting with an overview across markets and then focusing in on each market. On the left of this figure, we can see what happened in 2020. There were declines in all three markets, largest in Medicare Advantage. As a reminder, all these slides, on this slide, we're pulling out administrative costs, which is why the state trend looks a bit different than the trend I showed a couple slides ago. On the right, we can see what happened in 2021. Overall spending grew 8.2%, and this growth is almost all driven by commercial spending, with Medicare and Medicaid seeing spending growth below 2%. Just focusing in on the commercial market, we can see the modest 3.4% decrease in 2020 that increases to 18.8% in 2021. This averages out to about 7.4% per year, which is above the 3.4% benchmark. This 18.8% growth in commercial spending, I just want to note, is higher than what occurred in our neighboring states of Massachusetts and Rhode Island in 2021. Massachusetts saw 16.1% growth in per capita spending in the commercial market in 2021, and Rhode Island lower at 9.7%. This commercial per member per year growth comes in stark contrast to Medicare and Medicaid. In the Medicare market, there was very modest growth in 2021. So over the 2 years from 2019 to 2021, Medicare is actually trending negative at negative 4.0%. And as a reminder, this includes both Medicare fee-for-service and Medicare Advantage. Medicaid also increased modestly in 2021. I do want to offer a bit of context about what might be behind this modest Medicaid trend. As we can see in 2021, there was growth of less than 1% in Medicaid. And just for some context, during the public health emergency, Medicaid redeterminations were suspended. So the population covered by Medicaid grew significantly. We know that Connecticut Medicaid, the population gained 40,000 lives in 2020 and 108,000 lives in 2021. And we cannot confirm this to be the case, but there are many who believe that the folks that became eligible for Medicaid in 2020 then subsequently became employed in 2021 and gained coverage that they didn't end up using. And then that there were Medicaid folks covered by Medicaid that were not using services in 2021. So that's just some context behind this modest Medicaid trend in 2021. I'd like to zoom in even further to look at what is going on at the service category levels. When it collects cost growth benchmark data, OHS collects this spending in broad service categories. So hospital inpatient, hospital outpatient, not at the claims level, but enough to give off the sense for what is driving healthcare spending. So drill down analysis can be performed using other data sources. I'm going to focus on 2021 growth in service category spending, but the pattern of decreased spending in 2020 held true for most service categories with the exception of retail pharmacy. So please keep that in mind as we're looking at the following figures. Now, I just want to orient you to the service category graphs we'll be seeing on the following slides. These bubble charts are showing a number of different data points altogether. On the x-axis, we're seeing the per member per year spending for the service category. And on the y-axis, we're seeing the growth in the service category spending. The width of the bubbles is showing the extent to which the category contributed to spending going down or up. What you're seeing here on this figure is for the commercial market, for which hospital outpatient spending was the greatest contributor to growth in commercial spending. We can see that growth in per member per year hospital outpatient spending for the commercial market was 33.1% in 2021, with per member per year spending being just below $25,000 or $2,500. We see this trend in hospital outpatient spending as a significant contributor pulled through for both the Medicare and Medicaid markets. For the Medicare market, hospital outpatient and professional physician spending drove the increase in Medicare spending in 2021. When we're talking about professional physician spending, we're including primary care, specialty care, and any other physician spending in that category. Hospital outpatient also drove the increase in Medicaid spending in 2021, as well as professional physician spending. So as we can see, a key theme across the service category spending is growth in hospital outpatient as a service category. Just some takeaway observations from these state, market, and service category level analyses. Spending declined in 2020. This was consistent from what we saw in other states and was in the absence of federal relief payments that are not included in the cost growth benchmark data. In 2021, we saw modest growth in Medicaid and Medicare and very high growth in the commercial market. And across all three markets, growth in hospital outpatient services drove spending with more impact in the commercial market than in Medicare and Medicaid. I'm now going to move on to looking at 2021 total medical expense trends by payer. I will not be presenting large provider entity trends, but again, they are included in OHS's published report. What we're seeing here on this graph is commercial payers' performance against the 3.4% benchmark in 2021. The red line is the benchmark of 3.4%. Each carrier's cost growth is represented by a line surrounded by the confidence intervals that represent our statistical testing. As you can see, all of the carriers exceeded the 3.4% benchmark for the commercial market for 2021, with consistently high rates of growth, all above the benchmark and all in the double digits. With the exception of United Healthcare, cost growth in the commercial market for these payers ranged from about 16.6% all the way up to 18.9%. For the Medicare Advantage market, 3 out of the 4 Medicare Advantage payers were above the benchmark. We have an outlier in Aetna, which had negative growth that we are unable to provide context for. However, Anthem, United Healthcare, and Connecticut experienced growth ranging between 8.2% and 11% for 2021. Just showing a summary of payers' 2021 performance. Again, for the commercial market, all 5 payers exceeded the benchmark with double-digit trend, and 3 out of the 4 Medicare Advantage payers exceeded the benchmark in 2021. Again, putting this in the context of the COVID-19 pandemic, with a rebound in spending in 2021. However, noting that these trends are higher than what we've seen in our neighboring states. That concludes the summary of what OHS reported in its 2021 cost growth benchmark report. I'll now pass it back to Michael to share how OHS came to its identification of significant contributors.
Thanks, Grace. So, just to give some context, before we hear from those invited to appear today, I want to explain, how and why, they were invited. So, the statutory language regarding this hearing says that the executive director of OHS may require any payer or provider entity or any other entity that's found to be a significant contributor to healthcare cost growth in the state to participate in the hearing, this hearing. OHS has decided to select 3 types of entities to provide testimony this year. Might be a different set of organization types for next year, but for this year, insurers, hospitals, and drug manufacturers. And so I want to describe now the methodologies that we use to determine who should be identified. So I start first with insurers. So OHS asked 3 insurers, Aetna, Anthem, and Cigna, to provide testimony today. The reason for these 3 is that they all exceeded the 2021 healthcare cost growth benchmark, and they failed to meet the 2021 primary care spending target for the commercial market. So those were the criteria that informed selection of the insurer. With respect to hospitals and pharmaceutical manufacturers, repeated analyses performed by OHS, including using all payer claims database data, has pointed to cost growth, particularly in the commercial market, but not exclusively, being driven by growth in hospital spending and pharmacy spending. So for that reason, OHS determined that hospitals and drug manufacturers should be invited to participate, and then use the following methodology to identify which one. For hospitals, OHS asked the Hospital Central Connecticut and Yale New Haven Hospital to provide testimony today. To make this determination, OHS looked at change in payment per discharge growth from 2020 to 2021 using all payer claims database data, and also looked at the total number of 2021 commercial inpatient discharges for adults, that is those aged 18 to 64, in order to focus on the hospitals that have the highest volume and thus contribute to spending the most. The calculation adjusted for very high cost outliers when making the determination, and OHS found that the Hospital Central Connecticut payment per discharge grew 7.5% in 2021, and for Yale New Haven Hospital, growth rate was 5.9% in 2021, and those were the highest rates among the largest hospitals in the state. For drug manufacturers, OHS asked AbbVie and Bristol Myers Squibb to provide testimony. Here, OHS looked at those drugs that have the highest commercial spending in 2021 and in 2020, and then assessed those that have the largest increases in payment for 30-day supply. Again, this analysis performed with all payer claims database data. AbbVie manufactured in 2021 2 versions of the same drug, Humira, each of which increased in average payment for 30-day supply by over 7%. Bristol Myers Squibb manufactured 1 drug, Eliquis, which was in the top 10 drugs for commercial spending in 2021, and it had an increase in average payment for 30-day supply of over 8%. Last, as noted, or maybe not as noted, but let me share, what about advanced networks? Advanced networks are large provider entities in the state. That's the term OHS uses to reference them. OHS decided not to call advanced networks to provide testimony in the hearing, although we will hear from some advanced networks in a panel at the end of the day. And so that was the approach taken for this year's hearing. The advanced networks that were invited to participate in the panel or roundtable discussion we'll discuss how to improve healthcare affordability for Connecticut residents.
Great, thank you, Michael and Grace, for that overview of our findings. And that really sets the context for the questioning that will happen during our panels. So we are now running a little bit ahead of schedule, even though we started a little bit late. I think just to transition between this portion of the program and the panels, we will take a short break before we get to the drug manufacturers panel. That's slated to start at 11. If it's okay with you, Anna, and with, is it okay with Crystal Myers Squibb if we start at 10:30? Okay, so we'll take a 10-minute break to transition and then we'll start the next panel at 10:30.